Hola y bienvenidos a todos. Good morning, good afternoon, wherever you're calling in from. We are very happy to welcome you to the Latinx COVID-19 Task Force's very first launch of the HACER campaign. Today's webinar, we will be talking specifically about how we can be more inclusive of Latinx communities' gaps and needs, both during the COVID-19 crisis and beyond. So first, let's talk a little bit about who we are as a task force. So first and foremost, we were developed and brought together to specifically bridge a health and information gap through collaboration for Latinx communities in the midst of COVID-19. We have done that strategically through bridging partnerships with local, state, and national organizations and agencies across the United States. We specifically have come together to bring resources, data, and information that each of our organizations have been using in our communities to specifically talk about how we can address and inform the Latino community during this pandemic. Additionally, we have experts and expertise in communications, media, translation, and more importantly, how to be culturally competent when we address the needs of the Latinx community. And we also are in the middle of building our policy framework around the key needs the Latinx communities are facing right now. We are also a collaboration of over 50 partners and collaborators of organizations, different institutions across the United States. This is a map to show you the different organizations and their locations across the country. We also have over 100 task force members that are part of the coalition and of the collaboration. And I also wanted to mention a little bit of our task force timeline to you. So as you can see, the task force was launched in May of 2020 directly in response to the, directly in response to the needs of COVID-19. We had our first quarter evaluation in August of 2020. Of course, as many of you know, Latinx Hispanic Heritage Month was launched in September 2020, and we are currently wrapping up Hispanic Latinx Heritage Month with the HACER campaign launch. So as you can see, we are not done bringing attention to the needs of our community. In quarter two, we will have our website, our full website launch. In quarter three, we will have our strategic advisory committee convened. And at the annual mark, we will have our full annual evaluation to look at the next steps beyond COVID-19 for Latinx communities. So before diving into the impact, I also wanted to introduce myself. My name is Paulina Sosa. I'm the chair of the Latinx COVID-19 Task Force, and it really has been a pleasure to convene and work directly with the number of organizations and collaborators that we have on board with us today. So as many of you might know, and as many of you have, I'm sure, are already working directly with, unfortunately, the impact that Latinx communities have faced in the midst of COVID-19 has been disproportionate. What we see is, according to the CDC, the Latinx community now accounts for 34% of COVID-19 cases nationally. We see that Latinx children and adolescents account for 53% of the COVID-19 cases within that age group. We also see that Latinx communities also account for the highest proportion of COVID-19 infections amongst the 18 to 44 age group. And last but not least, we see the Latinx patients are hospitalized at a rate 4 times higher than their white counterparts. And these are just basic impact facts to talk about and set the stage for the general and disproportionate impact Latinx communities have been facing throughout the entire pandemic. So why are we doing the HACER campaign, and what is the HACER campaign aimed to do? So first and foremost, what does HACER stand for? It stands for Health Access for Communities in Emergency Response. We have broken up all of the different needs that have been brought forward by the organizations and collaborators in the task force into 3 main pillars. What we see is data, funding, and policy. We see that in data, and again, many of you likely already are working with this and have already seen the disproportionate representation of the Latinx community. So this particular pillar is aimed at focusing on the data collection, data reporting, and analysis of Latinx communities. We also see that for funding, there is a huge underrepresentation of funding and grants and different needs that need to be funded by different agencies across the country. So there is a need for funding for more bilingual and culturally competent staff. There is a need for funding for promotores and community health workers and organizations. And of course, translation services that really do feed and address the need in Latinx communities. And last but definitely not least is policy and ensuring that there is proper representation of the Latinx community across the board, that there is a recognition of the needs and the unique needs the Latinx community faces, and of course, integration of those needs and of the solutions that this campaign and the national statement we have built out are recommending for the country. So we wanted to share a little bit of the HACER campaign timeline with you as well. What we see is that we started with the national statement, which many of our speakers today have been a huge part in the development of this statement. This statement focuses on the key recommendations and solutions to addressing the problems that Latinx communities have been facing. We also have step 2, which is where you are with us today with this launch webinar, to really tell the public, these are the problems, but more importantly, these are the solutions. Next, we have our organizational sign-on, which will be going to our task force organizations and our task force partners and collaborators. But more importantly, we are extending an invitation to you and to your organization to sign on to this and to also endorse the recommendations and solutions that we are proposing to the national infrastructure. Step 4 is sending out a press release that will again bring attention to the key needs in the Latinx community, and again, those key solutions that need to be integrated both at a local, state, and national level. Step 5 is, of course, public engagement. The best way for grassroots efforts like this to be successful is for us to ensure that the community, that familias, that people on the ground have a say and have a way to engage with these national campaigns. And so that is something that we are doing, and we are starting that today with you. And step 6 is the advocacy efforts that we will be doing in alignment with a lot of other efforts around COVID-19 response and recovery, making sure that the key Latinx needs are integrated in the infrastructure moving forward as we reimagine what public health and health looks like after COVID-19. So these are some of the key asks. Many of you are probably wondering, well, what are you asking? So our key asks for the Latinx HACER campaign is, first, under data, we are asking for the adoption of the task force recommendations that have been brought forward and written into this national statement. We also want to utilize task force experts to inform Latinx-based data. As I mentioned, our speakers today, as well as other collaborators and partners in the task force, already have the expertise and the experience of what is needed in the Latinx community. So these are the people, these are the experts that should be asked about what is next. We also have funding. So making sure that we can expand capacity for culturally competent and bilingual services. We also want to make sure that there is expanded funding for services on the ground. And last but definitely not least is policy, and ensuring that there is an adoption of public policies that are recommended in the national statement, as well as providing protections for the Latinx community, both in the workforce and beyond. So we see that the foundation of these key asks is ensuring that the task force subject matter experts that are presented both here today and in the task force and the greater task force coalition are used and consulted to provide the expertise, the guidance, and the advice for what's next beyond COVID-19 in Latinx communities. So as we can see, urgent action is needed now. We have talked about the problem, we have talked about the gaps, we have talked about the disparities, and now it is time to act, and act on evidence-based solutions that our experts and our experience have come to say, this is what is next. So that is why you are here today. So let me go ahead and take some time to introduce our amazing panel of speakers. So as you can see, you have me, Paulina Sosa, who is going to be the moderator for our panel, but also for our discussion. We will be having a Q&A after the presentations, and we want to make sure that you feel comfortable to share your questions both in the chat and in the Q&A. We do have someone with the task force monitoring those questions that come in for the Q&A section that we have at the end. I first want to say a big hello to Michael Flynn, who is the coordinator at the National Institute for Occupational Safety and Health, NIOSH CDC. We also have Diana Lemos, who is the Senior Program Manager with the American Medical Association in the Health Equity Department. We also have Juanita Lara, who is the Mobile Health and Wellness Manager with the U.S.-Mexico Border Health Commission in the Mexico section. And we have Sylvia Trujillo, who is the Policy Director with Compassion and Choices. So as you can see, today's speakers already have the experience, the expertise, and more importantly, the data and the solutions for what is next and what we can do to be more inclusive of Latinx communities, familias, as we move forward beyond COVID-19. So without further ado, I want to hand over the floor to Mr. Michael Flynn, who will be talking to us today about what is next in being inclusive.
All right, thank you very much, Paulina. And thank you all, good afternoon, and thank you all for having me here. Basically, I'm going to be talking to you today about developing institutional capacity for a more inclusive public health infrastructure. As we all know, as we're all aware, there we go. Let's see. The United States is facing significant demographic changes. In terms of gender, we have changing social roles, and there's a move to non-traditional occupations by both men and women. We also have an aging population that's working later in life. Racial and increasing racial and ethnic diversity here in the United States. Minorities currently make up 40% of the US population, and by 2045, there'll be no majority group in the United States. This in part is driven by increasing numbers of immigration to the United States, and immigrants and their children are estimated to account for 88% of all the growth in the workforce here over the next 30 years. Looking at diversity through a public health lens, one of the key issues we like to look at is health equity. Health equity really concerns itself with the fact that how societies arrange themselves impacts who gets sick or injured, who receives treatment, who is healthy, and who is not. One of the biggest challenges to securing health equity is that by virtue of how inequities are created in societies, the same social structures and arrangements that contribute to health inequities also operate and are reproduced by the public health organizations meant to combat them. And so when we deal with issues of diversity, we need to deal with issues of more than simply difference. We need to work with conceptual models that address the inequitable distribution of resources, injury, and illness, along asymmetrical power relationships based on social axes such as race, ethnicity, class, nativity, etc. In short, it needs to deal with issues of power and privilege that are baked in to the social infrastructure. We need to understand that these are institutional arrangements, not necessarily personal flaws. The way society is set up influences these things, and we're all actors within that society. And so the goal is not so much to try and extract ourselves from society, which is commonly seen as, not seeing color, for example, but rather the goal is really to recognize what these social arrangements are, how they influence us as individuals, and how our own personal position within societies impacts what we see and how we understand and benefit or are disadvantaged by the social arrangements within society, right? One of the challenges to this is that the perspective of the privileged in society becomes the norm. It's sanctioned and reinforced by media, laws, and institutional practices. And another common dynamic is that privilege is often unacknowledged and understudied, making it even harder for many to see it and understand it. As Edward Hall once wrote, culture hides more than it reveals. And strangely enough, what it hides most effectively from its own participants. The real challenge, therefore, is not to understand foreign culture, but to understand our own, right? And so the idea is that we have to turn the lens back on ourselves and understand our own position and how that impacts how we are in the world, to be effectively work with people in different situations. To highlight this, I'm going to talk about an example of from a recent publication that we have. Basically, we cognitive tested the SF36, which is a Common Health Report survey, with Latino immigrant workers. So this was done in Spanish, but I've translated it in English here. And so one of the questions was, in the past 4 weeks, how often have emotional problems interfered with your regular daily activities? And a common response from the respondents was none. Now, if we just left the data collection at that, the scientific finding that we could glean from this data was that Latino immigrants have fewer emotional problems than respondents from other groups who had different responses than this. But in order to check our own assumptions that we brought to this, we had a follow-up question where we asked the people, can you give me an example of an emotional problem? And a significant number of individuals gave us examples about how getting excited turned into a physical ailment for them, kind of like the example we have here about a heart attack from getting surprised, like at a birthday party, right? And what we found is that people were conflating the term emocional or emotional in Spanish with emocionarse, or to get excited in Spanish. Now, the results are that we had two different understandings of the question. The difference is this highlights how this is more than just difference, but there's a power relationship here, because the unexamined assumption of the researchers, if left unexamined, becomes the de facto norms for this study, which then can become reified in scientific fact, which then influences, subsequent research or intervention spending, etc. And so this is how we can start to see how different, it's more than just difference, but they're baked in power relationships that give some impressions or perceptions more weight than others. And so the key here is to always find ways to check the assumptions that you are bringing, or that we are bringing to this research or the work that we do in public health, right? When we talk about developing institutional capacity, I like to think of three key areas, right? First is personnel, or who's doing the work, right? I think it's very important that, as we saw earlier, where you stand in society, your social position impacts how you see or understand or perceive the world, and how you are perceived by the world and act within it. And so it's very important that we bring people from diverse personal backgrounds to the mix, to the work, to ensure that the entire US population and the diversity within it is accounted for and effectively addressed, and that their perspectives and concerns can be brought to the table as we try and develop public health institutions, interventions, and research, right? We also need diverse perspectives from diverse professional backgrounds as well, to bring in different perspectives and have a multidisciplinary or transdisciplinary approach, right? But diverse perspectives are not enough. We also need to ensure that we're trained to acknowledge our own social position and how that influences the perspective that we're bringing to the work, and what we can learn or what we might not be observing in groups or individuals that come from different groups or perspectives than our own. The second key area that we need to look at are practices, right? Many of the speakers following me will be talking about specifics on different practices with specific examples, right? Anywhere from data collection to policy to interventions. But speaking in overarching terms, what we really need is a shift in priorities. Too often the dynamics around health equity and diversity is that there's a small group of professionals or individuals who feel passionate about this and are kind of the standard bearers of this. And it's seen as kind of an area of research or work that's adjunct to the work of the overall institution. And really what we need is an institutional culture shift where concern for the social determinants of health and health equity infiltrate and become a core value across all of public health. Now, this doesn't mean that every public health institution or every public health individual has to become a champion of health equity or make that the primary focus of their research or work. But we have to account for these social relationships, at least at a minimal level, for social relationships that we know impact the distribution of health and illness and well-being in society, right, across the board. And this is gonna require a shift in perspective. One of the key dynamics of health equity or of health inequities and diversity within society is that institutions or professionals tend to focus in a one-way format on the groups that face certain disparities or disadvantages. And it's all about trying to understand what is it about that group that's contributing to these disparities. Rarely, if ever, as I mentioned earlier, is privilege the subject of the study. And so we rarely turn the focus or the analytical gaze back on ourselves as professionals or institutions to say, well, what is it about my institution or the work that I do or how I approach it that makes me more effective at reaching or working with this group of people than with that? Right? And so they really need to develop this two-way street approach where not only are we understanding the reality of the other, but we're turning the gaze back on ourselves and understanding what is it about how we do things that impacts our effectiveness to work with people from different backgrounds. An example of this is with partnerships. It's common in the literature for Latino immigrants to be referred to as hard to reach. Yet anyone who's spent any time in the Latino immigrant community knows there are many institutions, some of which are represented on this call, who work daily and have no problem at all reaching immigrant worker communities, right? But when we call them hard to reach, there's a de facto blame that there's something about that community that makes them hard to reach. When we turn the gaze back on ourselves, and some of the organizations have suggested this terminology, they suggest, is it that we're hard to reach or that we are hardly reached by you? And what that really does is it turns the gaze back on the public health infrastructure to say, well, is it something inherent about these groups that make them difficult to reach because other institutions can do it? Or is it something about the way we've developed our practices and our procedures and the personnel we have working in our institutions that makes these groups hard, that has reduced our capacity to effectively reach this group as well as we reach other groups, right? And so that's a key perspective and an example of this idea of the need to establish a two-way street here. And finally, in terms of partnerships, really, as we move towards developing an improved capacity to deal with a more inclusive public health infrastructure, partnerships are an excellent way to develop this capacity in short term. Like I mentioned, there are many institutions that work within these communities. And so the key is identifying them and plugging into that infrastructure. The article I have here is one we wrote about kind of a model we developed at NIOSH on how to work with these community organizations. And one of the things we found is that we need to tailor our interventions and our studies to the work that's currently being done by these organizations. Many times these organizations are underfunded and overworked. And if we come in with the gold standard of a program on how to do things, it creates so much more work for them that while they'll be able to carry it on while the funding lasts in the short term that the project goes on, it tends to die as soon as you're done, right? But if we can tailor it and integrate it into what's currently already being done by these groups, then there's a tendency for it to carry on and be sustainable. And finally, I think what we do is that we need to look at building long-term and ethical relationships with these groups. Long-term means that while we want to meet the discrete objectives of each of the particular interventions or studies that we do, we need to know that each of these studies or interventions can build towards making a long-term relationship with these groups. And of course, they have to be ethical. We need to respect the work and expertise of these groups. So they need to also be included not only in the planning and execution of the activity, but also in the budget and ensuring that their work and their efforts and expertise are respected. So with that, here are some selected references and my contact information. We'll take questions at the end of everyone's presentation, and I'll turn it back to Paulina. Thank you very much.
Great, thank you so much, Michael. We really appreciate this information, and I think I speak for everybody here when I say that you know, this is extremely important, and I think this is one of those things that we many times forget. You know, it doesn't matter really which organization we're with, but I think in a lot of ways and in a lot of instances, we see at a national and even at a state and local level this lack of understanding of how to better incorporate and better institutionalize the way that we can be inclusive of Latinx communities. So thank you so much for providing this presentation. I think it really lays the foundation for what's next. And so, you know, as we kind of think about this foundation, I want to move next to Ms. Diana Lemos, who is with the American Medical Association, and she's going to be giving us a really overview snapshot of the impact and, more importantly, the data and the lack of data that we have representing our communities. So without further ado, I'm going to pass the microphone on to Diana. And Diana, I am giving you remote control now.
I think I'm on mute as I'm introducing myself. So let me see if I can get this on slideshow. It's always taking me a while. So this is from current slide. Sorry, I knew this was gonna happen. All right, so hi everyone. So thank you so much for having me. As Paulina already alluded to, I'm the Senior Program Manager at the Center for Health Equity. And I'm also a trained community psychologist who's been doing some research and just really trying to better understand what is happening within the Latinx community and COVID-19. So the first thing I wanted to start with is really to start to center and present the picture of why the data matters. And I think Mike did a really great job of really setting the tone around the power structures and how they're important and how that informs the response. So for today's conversation, I'd like to just start by first acknowledging that what we're experiencing is really the historic decimation of the Latinx community, along with that of the Black and Indigenous and other marginalized communities that we have seen that are being lost to COVID-19. And as Dr. Peter Holt has mentioned, it occurred to me that what we're really seeing is the historic decimation among the Hispanic and Black community by the virus. And this was in a live conversation to Congress. So with that recognition, I thought it'd be important to really center today's conversation on structural racism and COVID-19. Structural racism is harder to detect because it requires data to be examined over time, determine how the set of institutional, historical, cultural, and interpersonal practices maintain racial inequalities over a period of time. And with that, I'd like to also acknowledge that the key to responding to any epidemic is learning from the data that you have. So I think it's important to also recognize what data we don't have. And in today's conversation, we're going to really focus in on the different gaps that we're seeing. So this data gap is really resulting into the erasure of our communities. And I want to really bring to light some of these key statistics that we're seeing. So when the epidemic started back in March, for about 2 months, communities were advocating to have greater transparency around the collection of race and ethnicity. And over time, the number of states that have reported this racial and ethnic data has improved. Currently, we have 46 out of 46 states that report data around Hispanic and Latinx communities as it relates to cases. And here you can see that the highest rate of disparities is in Washington, where Hispanic Latinx people represent 12.5% of the population, but make up 29% of COVID cases. What this means is that Hispanic Latinx people are 6.7 times more likely to acquire COVID-19 than non-Hispanic white people in Washington. And we see these disparities in every state that we look at that collects this data. In terms of the number of deaths, we see that these disparities exist in 24 out of 47 states. And you'll note that there's still 3 states that are not collecting or reporting this information. What we see is that there is a disparity ratio that is present in 24 out of 47 states. And the greatest disparity that we see is in the state of Texas, where we see a 3.5 greater likelihood of people dying from COVID-19 than non-Hispanic white people in in Texas, sorry about that. So why is this important? I think it's important because these statistics are pretty dire if you look at them, but you also realize that the picture is not the complete picture. So what I want to focus on for the rest of the talk today is to talk about some of the things that we allude to in the report as it relates to data collection and the importance of the quality of the data and why that is needed for a responsive public health response, as well as looking at the transparency. Who is reporting, who's making this data available, and how frequently is it accessible. Also want to focus on the importance of data analysis and how we use this data to act and to provide an informed response. So it's important for us to have access to data for different groups and subgroups to be able to employ strategies that adequately respond to what we're seeing. So one example I'd like to start with is the data collection and the divergent quality of data collection. So COVID tracking has been reporting and collecting on all of the different states and providing the accuracy and completeness of the data. So for example, I'd like to note here that for Texas, for example, we have race and ethnicity data on just 6% of all cases, as compared to Vermont, where we see that we have 100% of racial and ethnic data completed. So again, why is that important? Because we're seeing that the story is then being driven by the amount of available data that we see here. So while we know that Latino people are experiencing the greater discrepancies in terms of mortality, we're still not very clear in terms of the extent of the infections in Texas, right? Because the rate of, the percentage of data completion is so low. I also wanna bring to light some of the quality of the data reporting and why we can have some concerns about how accurate this is. So here you see that data from CDC posted recently suggests that Hispanic or Latinx people are 1.1 times more likely to die from COVID than are white non-Hispanic persons. I also want to call to attention the fact that this is likely underestimated or not accurately captured. And to that point, I want to highlight the story of Roman. Roman died from COVID on April 1st. She was 46. Roman, a Latina, was identified as white in data from the Cook County Medical Examiner's Office. Again, this is not an accurate description, and that's a problem because without reliable data, it's harder to know the true extent of the impact on marginalized communities. And we hear this is also common for other groups like American Indian and Indigenous groups who are also being mislabeled. So the other part of the missing story is that we don't have comprehensive data about the Latinx community. So we need data on ethnic categories, on language preference, and occupational data. As we know, we're a very diverse group, and the diversity of our group has very specific nuances that are related to that. And we need to be captured and equipped with that information to be able to respond adequately. So the next part of the story that I want to tell you about in terms of the missing data is around the transparency around COVID-19 and workplace accountability. We've seen in stories that America's workplaces have been the primary source of COVID-19 outbreaks, with thousands of workers infected and dying. We also know that Latinos comprise a large portion of the essential workforce. We're a third of agricultural workers and a quarter of workers in the food, manufacturing, wholesale, and service industries. However, we are not able to fully capture this information and to understand the extent of the infection and outbreaks that is happening on the workforce because we're not collecting this information. There isn't a national surveillance system that correctly collects and accounts for this information. And also, while workers and employers are required to document COVID-19 infections, they are not required to report them. So what does that result in? So what we're seeing is that nearly 40,000 complaints have been documented related to COVID-19 inadequate provisions in workplaces since the beginning of the epidemic. What we're seeing is that very few have been investigated and very few have resulted in any type of fines or anything related to that extent. And what we're seeing here, what we're seeing in terms of the trends, is that it's not that there were deaths and then people started complaining, it's that there were safety complaints from the very beginning and then the deaths happened. So we're seeing that there was very little accountability in terms of what workplaces were doing. So the last part of the story that I want to talk about in terms of transparency is that when we're collecting data, we're relying on data quality, data assurances around what's being collected. And I'll just kind of highlight a little bit of the stories. I know I don't have a lot of time, but I want to talk about how things have changed in terms of what's required and what's reporting. And I'd like to call attention to what happened with COVID testing. In August of 2020, the CDC shifted its recommendation and said that people without symptoms may or may not need a test, even if they have been exposed to COVID-19, someone who has been exposed to COVID-19. So for a whole month, there was unclear guidance around who should or should not be tested. On September 18th, due to public health kind of response and requests, the CDC updated the recommendations to then reflect testing for asymptomatic and pre-symptomatic people who have had a previous exposure. So what happens as a result of this change? Well, there's a reduced demand for testing and also a potential increase in asymptomatic spread for a month. And we also know that this month happens to be the month where school starts, where there's a lot of learning opportunities that are now being shifted. So another thing that we saw is in terms of the COVID cases, there was a change in what tests counted towards a COVID test, and it varied by state. And we saw early on in the epidemic that the data released between states, what they were reporting to their public, and the data that was being reported to the CDC varied. And the reason it varied was because some of the tests that were more about detecting prevalence in a community were being used along with tests that were used to confirm a COVID infection. So the impact of this was it reduced the overall positivity rate. And so this was a false reduction, and it allowed for states to reopen or to move from one stage to a less rigorous stage in terms of their opening process. Now I'll highlight these two as well because these are important in terms of how we track data and how we are able to report it. There is also a shift in guidance in terms of reporting hospitalization data from the CDC's tracking system to the Department of Health Human Services teletracking system. And again, this creates unnecessary delays in tracking relevant information needed to triage patients. And then lastly, I'll touch on the COVID deaths. We know that we're still unclear around some of the data around death, and it really has to do with the differences in the way that people report, the different definitions, and also the methods for counting deaths. So what happens is that it results in an undercount of COVID-19 deaths, and this is particularly extreme for people of marginalized backgrounds. So why does all of that matter? Well, we use the data to act mostly, right? And right now, the way our testing strategy is, we're only really looking at people who are sick, who have symptoms, and people who want to be tested, who have the resources to be able to access testing. So who are we missing? We're missing the pre and asymptomatic cases. We're missing people who are uninsured. We're missing people with limited or no income. So for example, on this particular week, according to data from HACER, there have been 4.2 million tests completed. Of those, nearly 500,000 were positive. Of the people that tested, there was 30% of those who were Latinx or Hispanic. What you see here is that 45% or nearly half of those came back positive. Now what this means or suggests is that this community is only testing the sickest patients and that we're really missing milder or more asymptomatic cases. So why could that be? Well, we know also that access to testing is not available equally nationwide. In a recent study by ABC News found that major cities like Dallas, Miami, San Diego, and many other places in between, where there are majority Black and majority Hispanic Latinx neighborhoods, face far more competition for COVID-19 testing than their white neighbors. And this was also particularly relevant for low-wage communities who also face similar challenges. So here it's a little unclear to see, but you can see that there are so few testing sites in South Texas that potential demand for that consistently exceeds 600,000 patients per site. Similarly, in California, we see that it exceeds nearly 200,000 patients or more per site. And in the really white and almost really light blue sections, this is where testing is easily accessible, easily available, and evenly distributed. So finally, I'd like to say that when we have data available, it's important for us to analyze this data to make it available in a disaggregated manner. So we need to know the race and ethnicity at a minimum, the occupation and place. And this really allows for us to look and start to uncover some of these structural inequities and respond appropriately. One example I'd like to highlight is what's happening in the case of San Diego. Overall, if you look at the positivity state in the county, it is at less than 5% on a rolling average over the past 2 weeks. However, the hospitals and the testing sites in South County, an area that is 61% Latinx, reports positivity rates of 14% or more. And now this would require a rapid response. In this county, death data also shows that the Latino-white racial gap in the number of deaths is even wider when considering only deaths among people with no underlying conditions. So you can see that 60% of those people without underlying conditions are of Latino background compared to 24%. So this is a huge disparity. So what I want to close with is that, as Dr. Casares said, any public health response to COVID-19 that fails to share community level data and address structural inequities will perpetuate a false narrative about Latinx disparities and keep us from focusing on the real needs. So in conclusion, there are concerning gaps in data collection, data reporting, and data analysis. This obviously has a chilling effect on our communities, and we tend to be erased from the public narrative. What doesn't count doesn't matter. The existing data undermines our ability to accurately address the unjust impact on Latinx, Black, Indigenous, and other marginalized communities. And it also undermines our ability to advocate for more resources and to hold agencies, institutions, and systems accountable for those inequities. So I know that was a lot of data, and I know our other folks are going to be talking more about the responses. I did want to end on a more positive note from Dr. Maya Angelou. I think we can move beyond disparity because I look at the word at everything as if it is half-filled glass. I think the word disparity puts the weight on the already unencumbered. I think if I look at equity, I have a different image, more emphasis on opportunity, on seeking with more resolve, more hope. And that's what the rest of my colleagues will be talking about, all of the great work that's happening. Thank you all.
Thank you so much, Diana. This was mind-blowing, and as one of the participants said, very raw. And the reality is that this raw data really explains and really showcases the fact that we are not there yet, and there is a lot of work that we have to do as a community. So thank you for giving us that insight. And so without further ado, I'm going to be passing the mic on to Ms. Juanita Lara, who will be talking very specifically about an exciting partnership that has evolved and has grown and really has seen and made a lot of change on the ground. And she'll be sharing a little more details about that. So as I pass the controls over to Juanita, the floor is yours.
Thank you, Paulina. Let's see. Let's start this. Go down. Thanks. A little too far down. There we go. Great. So hello, everyone. Welcome and thank you for joining us today. My name is Juanita Lara. I'm here on behalf of the U.S.-Mexico Border Health Commission, Mexico section. Today, I am going to be talking about the Ventanillas de Salud and the mobile health and wellness initiatives. These are strategies designed to facilitate access to medical and preventative care and education for Latino and Latinx communities in the US. I'm gonna first start by talking about the target population that these specific initiatives target. Many of you already know these kinds of numbers, and I hope that most of you were able to fill out your census surveys before last night's deadline, but these numbers reflect a lot of the previous census and Pew Research Center information. So as you know, more than 11 million individuals or Mexican immigrants reside in the US. Mexicans continue to be one of the fastest growing populations in the US, but in spite of being the largest Latino group, high numbers of Mexicans continue to live in poverty and have no health insurance or access to health services or benefits. Economic status, limited English language proficiency, and limited access to healthcare services are among the most prevalent barriers to healthcare and directly impact the state of health of Mexicans in the US. The Ventanillas de Salud, or VDS, was an outreach and health access campaign first launched as a pilot project in 2003, operating out of 2 Mexican consulates in California. The success of this pilot project was duplicated to all Mexican consulates across the US. And today, the VDS program operates out of 49 Mexican consulates and attends more than 1.5 million individuals, providing more than 4.5 million services. And by services, I mean individual counseling sessions, vaccines, screenings, all types of screenings, and referrals to local medical clinics and hospitals. The VDS aims to improve access to primary and preventative healthcare services, increase public insurance coverage, and establish a medical home through information, education, counseling, and referrals to quality healthcare facilities in a safe and friendly environment. Each VDS site is operated by a local community organization that includes grassroots organizations, community-based health clinics, universities, and health research institutions, among others. And just a paraphrase here, while we initially target and our initial target population are Mexican nationals living in the US, we do not turn away any Latino or any person that visits our Ventanilla sites. And throughout the years, we have seen that not only Mexicans, but all kinds of folks from Central and South America have reached our Ventanilla programs, and a lot of mixed status families, families who have undocumented relatives, US citizen children, or folks in the process of becoming permanent residents or asylum seekers, as well as other types of visas. The primary characteristics of a Ventanilla de Salud reflect the core mission and vision of our network of community organizations that work directly with the Mexican and Latino communities in urban and rural areas. Among these characteristics is relationship based on trust and empathy, personalizing needs of the community, culturally and linguistically appropriate information developed in various indigenous languages as well, and creating a healthy and welcoming environment that reduces stress, makes healthcare more accessible and approachable. Based on the needs of the community, agencies prioritize health topics such as diabetes, breast cancer, cardiovascular health, and diseases known to be rampant in our community. So at its core, the Ventanilla de Salud program, while it's operated out of our Mexican consulate sites, it's really the community-based organizations that drive the work that comes out of it. Not only are the VDS operated by local community organizations, these lead agencies have a network of allies and partners that contribute to a holistic and comprehensive approach to community care. And these partnerships that these agencies have, and here we have an image of a lot of the folks that represent the coordinators of the Ventanillas at each of our sites. Each of our sites has a network of their own collaborating agencies, allies, and partnerships in their own cities. And what we have seen with these multi-level, multi-sectorial collaborations is that we have a greater success in running campaigns such as influenza campaign. In any given year, an influenza campaign started by our network can yield over 50,000 influenza vaccines administered throughout the entire US. And that's an impressive number, but however, as we see how huge the numbers are and the data that's needed from the previous presentation, we know that there's still so much work to do. Collaborations also increase screenings and detections from hard to reach communities, which means that we have a greater percentage of detecting early diseases that can be preventable. The VDS operate through a multi-sectoral collaborative network of more than 500 local partners, each site adapting to the needs of the community. Some examples of these are, Oxnard and Fresno, for example, have some of the highest farm worker and agricultural populations. So a lot of their work really target those communities. New York and Chicago, being really dense urban cities, target populations that work in construction, tourism, and restaurant businesses. And additionally, we have 10 Ventanillas de Salud that are along the US-Mexico border. They serve populations that not only live among the toughest weather conditions, but among the most tense political environments in this country. In 2016, the success of our VDS program with the success of our on-site VDS program, the US-Mexico Border Health Commission launched the Mobile Health and Wellness Initiative as a sister project to the VDS, making this strategy, taking the VDS strategy and putting it on the road. There are 11 mobile health and wellness vehicles sprinkled throughout 11 metropolitan cities across the US. Now, urban, rural, and rural communities with difficulty in access to services and information are visited by this mobile clinic and provided services. Unbeknownst to us at the time, the mobile health and wellness became the lifeline of many rural communities during this global pandemic. In spite of the closures and in spite of all of the pauses across the US, many of our mobile health units partnered with local hospitals and medical clinics to go out and provide services to rural communities that didn't have access to them before. They became mobile testing sites. They distributed safety equipment such as masks, gloves, and sanitizers or sanitizing liquids. They shared more education and preventative health around the COVID-19. And one of our mobile health units was actually featured on Univision's Jorge Ramos section as providing one of the few agencies that was providing testing services to undocumented immigrants in the area. Many of you are familiar with how funding works. Many of these collaborations that we are seeing with the Ventanillas de Salud and the mobile health and wellness programs are forming now in anticipation of what is to come with the vaccines and information. But these relationships have been nurtured for many years prior. Trickling down funds. Many of you know how federal funding works, where federal funding trickles down to state funding, trickling down to city funding, which then somehow, sometimes trickles down to community-based organizations. But as mentioned in prior presentations, a lot of this funding is lacking. There isn't enough funding, or there is enough funding, but just not funneled to community-based organizations that are actually doing a great deal of the work, which is unfortunate. We translate, we tell our stories, we're able to access communities that larger institutions are not able to access. However, none or very little of the funding that's designated for these communities make it to the community-based organizations that do this work. We are still excluded from a lot of the stimulus package, and we're excluded from a lot of the funding that is being developed for what is to come with the COVID-19 vaccine and information. In closing, I just want to mention this. The Ventanillas de Salud program and the mobile health program are successful because of the agencies that work there. I have the privilege to work with some of the most dynamic and extraordinary small organizations across the US that really put themselves out there to connect with their community. And that's because they have a network of promotoras, a network of community health workers that come from these communities, and there's a atmosphere of trust, and there's an atmosphere of what they call confianza, right? They trust these folks, so they're able to really, you know, connect with these communities and provide the services that they need. But there's a lot of things that we need to sort of put ourselves out there in order to access some of this funding and to continue being able to sustain the work that we're doing. We need to build our relationships with our city and state departments of health in anticipation of what is to come with the influenza vaccine, as well as keeping our community informed about this vaccine. We need to consider more collaborative fundraising with other agencies. This network of agencies sometimes gets together and funds collaboratively. And some of the larger pots of funding that are usually offered to large institutions, many foundations and many institutions that are donors of this will consider funding collaborations between a group of agencies if they can see that they really work well together and that their target population is something that they're interested in. We absolutely need to know the worth of our agencies. Our ability to flow between multi-language, multicultural communities isn't just, you know, isn't a soft skill. It's a very difficult skill. It's a learned skill. It's something that our promotoras and our community health workers do very well, and they've done very well for a very long time. We need to capture our impact through our creative storytelling and testimonials. In addition to all this data that's needed, we also need to capture the stories and the impact of how not just this pandemic, but all of these medical barriers and illnesses that our community lives with. We need to capture those. We are a culture and a community of storytellers, so that should come easy to us. And finally, if there's anything that this global pandemic has taught us, is that we cannot do this alone. And the Ventanillas Salud program in our mobile health unit is one extraordinary example of how a network of small community organizations have come together to really, really make an impact. And while the impact is big in terms of what we're aiming to do, there is still so much more to do. And the program, in my opinion, is a program that's able to be duplicated to other institutions and to other networks, which I'm happy to share and converse with later. But we need to, I think, if we can collaborate together more, then our impact can be much, much greater. Thank you.
Thank you so much, Juanita. And, you know, I think, you know, Diana ended on a note of hope, and I think you're diving into what that hope looks like. And so as we transition to the next PowerPoint, I just want to say that one of the beauties of Nuestra Comunidad is that power of storytelling and is that power of partnership. And so, you know, there's a lot of work for us to do, and I'd love to hear in the chat if any of you have specific stories on doing these on the ground collaborations and partnerships, because the reality is that, as Juanita mentioned, we are stronger together. And so with that, I'm going to pass the remote control to Ms. Sylvia Trujillo, who is going to talk a little more about integration and inclusivity in policies. So that's a whole other world, and that is also just as vital as the data, the partnerships, and the institutional inclusivity. So Sylvia, the floor is yours.
Great, thank you so much. I want to thank you, Paulina, in particular, for the incredible job that you've done to really pull us together and get our presentations where they need to be as we move forward. So I'm also going to take the liberty to make sure we have enough time for Q&A and I don't go over my 10 minutes. I'm going to put an alarm on. So if you hear a buzz, that means my time has been called by me. So in light of the benefits that we've outlined with regard to storytelling, this presentation really is going from the macro, talking about what Congress does and what they have done, intersperses what that impact has looked like over the last several months since the pandemic for our community, and then zooming into some use cases, both of inclusive policies and those that have not been, and then finishing up by focusing on the fact that there are two very large packages sitting in front of Congress that cover many of, at a policy level, the issues that we covered here around testing, data collection, social determinants of health that are driving the disparate impact of the pandemic, and then circling back to the broad outline of what Paulina laid out for us in terms of what we as a task force in a community should be asking for, and outlining as key policies to really remedy the deficits that we've seen in not just the public health response, but the healthcare response as well. So I think it's, there's a lot of data. We need to really hone in on that data, and we've had some very impactful depictions of that data. I think it's really important for everyone to remember we're the largest ethnic, racial minority in the nation. That often is obscured. And it's also really important to underscore for everyone that we're not talking about a really small number here. If it were a small number, it'd still be very important to address the impact for vulnerable populations, which we most certainly are. But we're talking about 1 in 5 people in this nation where we are experiencing a disparate impact. And I think it's important to remind people of that. Given the time limitations and the fact that this is a public health association, I'm not going to go through the key steps that all of us should know back of our hands about what constitutes an appropriate public health response. But I highlighted here for steps 2 and 3 that essentially this is where we're at. And so we need to assess ourselves as a nation, as communities, and as advocates for our community. Are we doing enough to ensure that we are advancing these best practices in our community and policies and programs? So just a reminder that we have appropriated and authorized as a nation more money in a sort of condensed period of time to address COVID-19 than we've ever spent at any one time in the history of our nation. So 2.4 trillion has been allocated across 4 packages. I'm going to really just hone in on one of those packages, which is called the CARES Act, and it was the third of 4 of the packages that have gone through. And it is important because it was the most significant in terms of the public health and the healthcare specific components. But all 4 packages actually address the impact of COVID-19 and what are the social determinants of health. They impact what happened in small businesses and big businesses and schools, what would happen in our hospitals. And so it's also important to note that there was a disparate negative impact that was alluded to earlier, and I'm going to expand on a little bit. But those social determinants of health, with regard to the fact that Latinos are disproportionately on the front lines, disproportionately adversely impacted in their small businesses, and therefore, if they had health insurance, they lost health insurance. These are all drivers that are multipliers of the spread in the context of a public health pandemic that we are looking at. So keep that number in mind, 2.4 million. What did we get for 2.4 million? Not just as a community, but as a nation. So honing in for the CARES Act, early in April, we were looking at just under $1 billion was both appropriated and authorized, and then targeted for distribution by the CDC with a public health lens. Now, again, this doesn't include very large sums of money that were allocated and appropriated and authorized for our healthcare system. But this is, I think, illustrative of what does institutional inclusion look like from a policy perspective. So not surprisingly, these were allocated for the standard public health best practices. We're looking at containment, surveillance, testing, and then in monitoring and assessing and supporting healthcare system capacity. But very importantly, also for controlling COVID-19 in high-risk settings and to protect vulnerable or high-risk populations. I think we can all agree, based on the presentation we just had, that certainly the very diverse and variable Latino community, including a large percentage of immigrants, would qualify as such. So how did we spend that billions of dollars, and how did it impact our community? Well, our first two presentations really delineated that impact. So I'm not going to belabor the point. I think both Diana and Paulina laid out the numbers. They're sobering, and basically what you're seeing, if you just look at the red here means that there is a disparate impact, that the Latino overrepresentation in terms of COVID-19 cases is much higher. The redder, or the darker the red, or the pink, whatever color you want to call it, which means that essentially that means there is institutional exclusion. $1 billion, where did it go? And we know where it didn't go, certainly. So in short, what you've heard today thus far, institutionally as a nation at a macro level, there was no rescue packages for the Latino community. We can safely say that, despite the fact that not only were there funds awarded for public health, but there were funds that were supposed to be awarded to help rescue small businesses. There were supposed to be funds appropriated to help with a host of safeguards for employees in high-risk jobs who were essential workers, and yet we have not seen those funds. And we want to then sort of zoom in and think about, okay, well, that's a broad statement. What does that look like on the ground? So in North Carolina, really at the beginning of the pandemic, it's an instructive use case of what we've seen all throughout the country. And what we've seen in this particular state is, at the outset of the outbreak, there were some very resilient communities and very resilient Latinx leaders who very quickly came together. And the Latin 9, which I will talk about shortly, organized weekly meetings of community members and physicians at Duke. And it was started by a group of Latina physicians. And what they found, despite the fact that they organized in March, that by May 2020, the overrepresentation of Latino cases in North Carolina was, despite the fact that Latinos are only about 10% of the population there, 50% of the cases at that time were Latinx. In Durham, 70%, despite the fact that the population there is only 14% of the population. So really drilling down to what we know at a visceral level in terms of storytelling, what does this look like at a personal level? And I just want to hone in on one of the sort of final pieces from a blog post that was provided about this meeting. And I'll highlight it. It's the quote from the priest, where, because the system had utterly failed on every mark, from the sentinel capacity, the data and surveillance capacity, to the tracing, to the providing services, the appropriate quarantining, and the services to mitigate. Instead, what our community was doing was trying to figure out ways to die at home. That is what a public health failure looks like. So, what are the bright spots here? And they are here. So it turns out in North Carolina, the numbers are still really problematic. Latinos are still disparately overrepresented in the reported cases, even though we know from Diana's reporting that even that we don't know is entirely accurate, because we don't know that we have transparent reporting. But what we do know is that we have several organizations that have, and it looks like I'm way over my time, so I'm going to speed this up. So I'm going to wrap this up, if you give me dispensation, for about 3 minutes. So the Latinx team I mentioned earlier partnered with Compassion and Choices to develop and promote and push out with yet another organization in North Carolina called the Community Health Watch, a COVID-19 System Support Program. And through the influence of both Compassion and Choices, Latin 19, the Duke Community Health Watch program, which is a Sentinel system, translated their materials into Spanish, hired Spanish-speaking staff, and had folks who were culturally competent and connected to the community. And they now have partnerships with community-based organizations affiliated with churches, and they're expanding. They elected in North Carolina to spend their CARES funding for community health workers and organizers who were from the community, as opposed to requiring that they expand existing capacity for public health workers. And so they're starting to see their numbers decline. So this pushes us towards, okay, we have a couple of models, and we've heard folks talk about some successful methods that really involve community workers who are integrated into the existing ecosystem of our varied and multifactorial community. And now we're pivoting to the CARES Act funding is running out, a lot of that at the end of this year. And we are now looking at an impasse in Congress between different strategies and policies to address our still very serious public health crises. So I've outlined here in this slide the funding that passed the House, the democratically controlled House. And you'll see here that there's funding for frontline workers, workforce training. There's a really significant difference in the amount of funding allocated and appropriated in what would be authorized for contact tracing, $75 billion versus $15 billion. I also want to call out that in contrast to the funding that would be made available for frontline workers and important protections, which several of our speakers already talked about as an important issue in this pandemic, the Senate bill would actually give employers immunity for failure to implement best practices for purposes of preparing their workers and protecting their workers from a COVID-19 exposure. So those are some clear policy differences between these packages. Funding that we talked about for contact tracing, protections for workers versus immunities for employers who don't. And then last, but certainly not least, we are looking also at additional funding to expand the public health response and strengthen it. Pretty disparate distribution of what that funding would look like. And then last, to Diana's presentation, really identifying additional fundings to help the CDC improve their collection of information. So the task force has outlined a number of recommendations. They were outlined at the very beginning around accurate and timely data collection, analysis, and reporting. Juanita laid out very eloquently and clearly that we have a compelling need for public health workers with unique and necessary expertise. These aren't soft skills that she said. This is a highly honed, acquired expertise, a lived experience, and equally important, an ecosystem of networks that have been maintained over a series of years, that these need to be funded at the community level, strengthened and given the resources to do the work that they can. And that these have to be prioritized, quite frankly, over other organizations that may be larger, more well-established, maybe more well-known, but that don't have that type of integration into the system. And then last, we've already all touched on, and I referenced it in the national funding, we need real protections for our frontline workers. This disparately impacts our community, but it's important for all. And additionally, the funding for testing and treatment and educational services without regard to a person's status or whether or not they have health coverage, collaborating with diverse communities. And last, a personal favorite for mine that's rarely talked about, but using technology to innovate in ways that empower individuals, not systems, to help guide their care and help arm their families in languages and in modalities that are readily available to them, with regard to how to protect themselves and then how to act when they in fact may have COVID, and how to help their family members too. So thank you very much for indulging me.
Thank you so much, Sylvia. And I think that you did a fantastic job of just wrapping up all of the different pieces. So what I want to say is, and here I'll go ahead and close this here. So what I want to say, and I know we're close on time, but my hope is that for everybody in attendance right now, that this has not only shed light on the realities that I'm sure many of us are already familiar with, but that it also gives us hope collectively for really an effective solution to address these problems, because these are not new problems, right? These are problems that have been issues for decades. And COVID-19 has given us, and it's weird to have to say it this way, but it's given us institutionally, societally, nationally, an opportunity to address these problems and find solutions. And so I think one of the key messages that drives home today is the fact that we are not an afterthought. We cannot continue to be an afterthought. And so we have brought together these key recommendations for the country, for local, state, and national organizations and entities to consider to really appropriately address the Latinx community. So thank you so much, Sylvia, Diana, Juanita, and Michael for bringing all of this home, because all of this is interrelated, all of this ties together. And so I do want to have a quick Q&A, and I want to encourage our participants to please share your questions. Unfortunately, we won't be able to get to all of them today, but we will make sure that we are able to answer your questions offline after today's webinar. So I'm going to go down the line of our speakers and ask one pointed question to each of you. And if you could also please, provide a brief response to the question, but also if you can also just share any kind of closing remarks as we'll close out after the fourth question with some of our calls to action to the audience. So, so Michael, I wanted to ask you, specifically, you talked about this culture shift. And I think, the culture piece is so big for us, right? When we look at Latinx communities. And so I wanted to ask you, based on your experience, what you've seen, your research, how do we do an institutional culture shift when it is so deeply ingrained already? These cultures are so deeply ingrained with so many associations and federal agencies in our country. So what do you think the solution is for that? And if you can also give us a quick closing remark when you wrap up that solution.
Sure. Well, I mean, I think it really, there's no one clear answer, right? I think each of us has to work on it from where we are. Those who are kind of outside the system or representing the community, working in the community, have one role in making this happen. Those of us that are working, inside these institutions have another way. One thing I'm particularly proud of is the relationship we've developed over the past 10 years with the Ventanillas de Salud that Juanita works for, and it's one of the models we've been able to do. And little by little, we've been able to open up, I think inside both NIOSH and CDC at a larger level, the possibility to show them kind of, success breeds success. So I think, a lot of times, at least internally, what we've tried to work on is demonstrate, find that little opening where you can get some funding, do some work, show some positive results, and then try and sell those around, and I think if there is a silver lining to moments like this one, with COVID, and then the issues, just around equity in general in the United States right now, the silver lining might be that it does open the door for people paying more attention to inequities, and also a willingness to maybe try things and take a risk on, partnerships or ways of doing things that are a little different than how they have traditionally been done. So I think it's being smart about, knowing the political moment and seeing, okay, can we leverage this moment to try and create, you know, possibilities and opportunities? And then again, like I was saying, having it not just be about a one-time event, but seeing, you know, how do we develop that one-time intervention or possibility to structure it in a way that will facilitate, you know, an ongoing relationship, or making it relevant, you know, once COVID ends, perhaps making it relevant to, you know, routine flu vaccines, for example, or other type of thing, you know, other type of intervention. So I think it's just knowing where you stand, you know, in society, in the public health infrastructure, so to speak, and looking for moments and opportunities, even if they're not going to solve the whole situation, they do provide an opportunity to get your foot in the door and push it open a little further. And then other than closing thoughts, you know, this is just want to thank you again for inviting me to join this. And I think events like this as well, raising awareness about the deficits of the current system and how it could be improved, are a great way of continuing to move things forward. You know, they're baby steps, but we do keep moving forward, and that's the important thing. So thank you all very much.
Thank you so much, Michael. And I think that that's a really great way for us to approach wherever we are in our organizations, our in our day jobs, and as a student, as a professor, wherever we are, we have an opportunity to act and increase awareness and promote change. So thank you so much, Michael. Really appreciate your thoughts and your feedback on this, and looking forward to next steps. So the next question I wanted to direct to Diana. And so Diana, you provided a really large slew of really impacting data that unfortunately not everyone has seen this yet, and hopefully this will get out to the people that it needs to get to. But I wanted to ask you specifically to data reporting. How do we as experts and you know, as experienced as we are with the Latinx community, how do we provide true guidance to really create accurate depiction of the Latinx community in regards to data reporting and visualization and everything else that follows?
Hi, thanks for your question. I think that one thing that I realized, and this has been quite the journey of learning and also really uncovering how data is collected and how those decisions are made. So this is a year where, you know, collection of race and ethnicity data has been such a hot topic. It's not just related to COVID-19, it's related to the census, it's related to other things that are happening at the moment, in which we know that there are efforts to try to silence or to you know, change sort of the descriptions and the definitions. And it's also a moment where we, as a Latinx community, have sort of been thinking through how we define ourselves, right? And the idea and the definitions that resonate most with our community. So I think one of the things that for me was really important was to uncover how these definitions are adjusted or reflected, and it's political, right? And there's a political reason as to why these particular data points are collected, why they're not collected, why they're adjusted and how they're adjusted. And a lot of it has to do with, you know, public opinion or the lack of public opinion, right? So when we looked at the categories, when I was trying to understand why we don't have ethnic categories that are available for the Latinx community, it was definitely proposed in particular stages. And if you look at the decisions on openings and community hearings, you'll often find that maybe one person raised a point and that was the point that was made, right? And so again, how these are defined, we all have a voice and an opinion and a role to play to say, this is how we need to collect this data, this is how we need to be represented, along with us as professionals to continue to advocate for those and to really understand why it's important. You know, how we define issues is how we define the solutions, right? And so I think the narrative that has continued to change and the challenge that we have is that because we collect data on communities, we have to be really careful to not then, you know, shift the blame on communities. And so I think that was one of the initial things that was really concerning to me as I was starting to do some of this qualitative studies. So I loved all the people on the panel who were talking about storytelling and sharing stories. because I think it was really apparent that a lot of the things that we were seeing in the media were really kind of placing the blame on the Latinx community and saying, well, they live in crowded housing, they're still going to work, or they don't have access to PPE. But when you have the power, as we do, in our institutions, in our places, then we can start to change the question, right? And when you change the question, the solutions are then different. And so again, the importance of just having the narrative that drives our research or drives our public health approach is important, but it's also dependent on the extent and availability and reliability of the data that we have. So it's not just one or the other, but I think it's important to continue to do that work. So yeah, and in terms of closing remarks, super grateful to be here today. Thanks for being here. I've learned a lot as well from my colleagues, so I appreciate being part of this. And yeah, I think we just have to continue to shed light on these injustices that we're seeing.
Thank you so much, Diana. And I hope that as people are listening to all this, that this again provides that encouragement. And I know that to be mindful of time, I'm gonna still ask the next two questions, but so we appreciate anyone that's able to stay on just a few minutes longer. So Juanita, I wanted to ask, and first thank you for presenting such a crucial partnership that has really made a huge impact in the Latinx community. This is a great model of how we can really impact our community and work together in partnership. And you talked a lot about key partnerships. And so I think one of the big topics coming up, and you touched on this a little bit with flu vaccines, but is the upcoming vaccine. And we are about to start the flu season, but I just wanted to get your thoughts on, how has it been to reach out to the community and encourage them to take the vaccine, and what do you foresee with the COVID vaccine, how that's going to happen? I know it's a loaded question, but I just wanted to ask for just some brief thoughts on your response to that.
Yeah, that's a great question. And I think that that's something on everybody's mind, right? Like, what's going to happen? What's coming? When is the vaccine going to be developed? What are the side effects? As we know, there's all types of information that is being shared, not just online and through social media, but through the news. And the truth is that what becomes so important about the partnerships that we've had for such a long period of time is that you build trust with them. And as we've learned throughout the years is that we scrutinize the type of information that comes in before we disseminate it, right? Who is it coming from? What are the resources? What are the citations? What sources are they coming from? How valid is it? How not valid? We translate it in a way that is understandable, not just linguistically, but culturally. And all of this takes time, but we do it because of that relationship that we initially built with the communities that we work with. It's as if we were speaking to our own relatives, right? And I hear this a lot from the promotoras when they go out to talk to their neighbors or their community members. It's they see their family in them. So if they're going to share information, they want to make sure that that information is valid, that it comes from a source that's trusted, and that and above all, that their community is going to understand that. We don't know what's going to happen or when the actual vaccine will come in. I think there's a campaign out. I forgot what it's called. I think it's Operation Deadline, Operation, it's on the CDC website, but it's got a funny name to it. And it's like this countdown to when the vaccine's going to show up. And all I can say is that as small organizations, we need to prepare ourselves for just before the vaccine shows up, when the vaccine shows up, and especially after the vaccine is starting to disseminate. Why? Because our community counts on us to keep them updated with this information. We need to be involved in the process of disseminating that information and, if possible, the actual vaccines when it comes down to it. And the post, what happens if there are side effects? What happens if a community, was completely neglected and they didn't get any? Or where can they get some? Or anything that might come up afterwards. So we need to be very involved in that entire process. And just as a closing remark, I mean, everyone's presentation was so full of information. these are conversations that need to continue to happen, right? We want to get so much information and we want to share so much information now, but the truth is that these conversations need to happen more often. They need to happen very specific. With each of us could take on an entire presentation with all of our topics. And I know that I definitely have a lot of questions for my colleagues afterwards, because I'm just so interested in their views and the additional information that they have. So I'll just leave it at that this is the beginning or a continuation of the types of conversations that we need to have moving forward. And I'm looking forward to those talks.
Thank you so much, Juanita. And just as you said, this is just the start. So many of you that are joining us today, this is going to be an open conversation with you too. And so last but definitely not least, I want to just ask our last question to Ms. Sylvia. And so Sylvia, you talked a lot about the funding gaps and really the fact that there was no rescue package for the Latinx community. And you're right, there wasn't. And so one of the questions I wanted to just quickly ask you before we close out is, how can we assure, and I know this is a loaded question as well, how can we ensure that this funding, the funding to come, does actually reach the Latinx community? What can we do? I know this is a little bit of a call to action as well, but what can we do to make sure that the funding does get to the Latinx community?
So I think that's an excellent question, and that is the crux of the matter, right? We can't do the work from thin air. And so the short answer, and it's a very practical one, is that we need to make sure that the contents of this presentation and the many more are not just presentations to an echo chamber of folks that know what the problem is, that we have social media campaigns. We utilize partners like Radical Health. There was a question from Leonor Osorio on this very issue, and we need a campaign on an issue. It's not a partisan issue. It's on a substantive issue around public health solutions. And that campaign should be targeted to our local officials, our county health officials. It should be our state legislators, and really critically important right now to Congress. And I really want to emphasize this point. There are two very different packages before us, and there will be no funding for anyone under one of the skinny package that's in the Senate. So if we do get a package, which that is the question of the hour, are we going to get a relief package? It really is going to probably have to look a lot more like the HEROES Act, which passed in May and is sitting at the House and hasn't been taken up by the Senate, in order for us to get a solution. So that means we need to make sure that we're briefing not just the Congressional Hispanic Caucus. They already know this, they're members. We really need to be giving our fellow colleagues on this discussion materials so that they can go to Congress and they can say, this is what we need. And by the way, we were not part of the last packages, and we want directed appropriations and authorizations that are very specific about vulnerable populations, underserved populations, and that these funds are not just a blank check for folks to spend, but that they're going to be spent in a targeted way. And by the way, that's the right public health response for everyone, because when you have 1 out of 5 people in our community that are not being reached, and it turns out they're disparately impacted from a public health perspective, that is where you actually should be prioritizing your resources in order to get ahead of a situation where we are so far behind.
Thank you so much, Sylvia, and you did a great, fantastic job to transition us to the calls to action. So I again just want to say a big thank you to our wonderful panel of experts and speakers. Thank you, Michael, Diana, Juanita, Sylvia. The conversation continues, and so many of you are probably asking and wondering, well, where are these materials? Where can I get the recording? Where can I get these slides? Because you know what, I want to share it with my job. I want to share it with my colleagues, and so all of this is going to be available for you at our website. website. So as easy as 1, 2, 3, we're encouraging you to visit our website and stay engaged. If you want to join this conversation and strategically be part of the conversation and the recommendations that we will be pushing out, please let us know directly. We also want to encourage any organizations that are on this call to sign on to our organization letter. As all of the speakers have shared, this is a collaborative effort, and we are only as strong as we are when we are unified. And so I think the constant and the continuous message during Latinx Heritage Month is that unidos somos más fuerte. So even though Latinx Heritage Month is coming to a close this week, we continue forward. And there are also additional activities for engagement. So for those that are wondering which website, I believe Gladisa has shared the website in the chat, but this is also our website, latinxtaskforce.org/HACER-campaign. So please visit us there. That's where all of these materials, including the recording and slides, will be, as well as the link to our organizational sign-on. So again, if you have specific questions or specific ways you want to be involved as an organization, you want to get engaged with us in the task force and join our strategic meetings, please let us know. And of course, the sign-on link will also be available on the website. And last but definitely not least is, as individuals, each of us have a voice. So we have a series of different actions for you to kind of be engaged as we roll these out. So some of these are still being developed, but these will all be rolled out on the website, signing on to a series of nonpartisan letters that we will have later in the campaign. Also sending letters on behalf of your own institution, using specific HACER recommendations, contributing, as I mentioned, to the national statement, to build awareness and specifically around ongoing challenges that maybe you've seen in your community or that you've experienced yourself, and circulate this request for action to other organizations that may be interested. And last but not least is, of course, we need to involve and engage the media. So if you're interested and able to write an op-ed, we'll have materials for you to do that. And if you'd like, we can also collaboratively work together with you on that. So I hope that this webinar and this launch of the HACER campaign not only really brings to light some of these key facts and this key information that is out there about the Latinx community and what's next, but I hope that it inspires you and encourages you to also join the movement and act with us. The task force is aimed to both ask, address, and act. And that's what we're doing right now with the HACER campaign. So again, a big thank you to our amazing panel of experts, virtual round of applause for them. And again, a big thank you to all the participants for joining us today. Thank you for staying on a little later. And we hope to see you online beyond today's webinar. Muchas gracias y nos vemos.